Okay, and here we are with our cornea transplant action plan team. And this team spent the last over 7 weeks conducting a deep dive analysis on the need for ocular tissue transplant. And they created an action plan to uptake this program at FIBUSPAM. I would love to bring up the contributions of Dr. Carlos Gonzalez and as well, and also Dr. Silla Ball for their contributions, and not just on background information, but also some direction to the team. It was very, very valuable, but I also must bring out the contributions of this team and how much they dove right into this topic. It's a very, very new topic to every single one of them. And I'm very excited to hear about just what they've put together. I've checked out a few parts of their progress along the way. And I think this is going to be really exciting. So Tristano, could you please introduce yourself?
Sure. Hi, everyone. I'm Tristano. I'm a rising junior at Princeton University. I'm doing a BA in psychology with a certificate in neuroscience. Next to me is Meredith.
Hi, I'm Meredith. I'm a rising senior at Princeton, and I'm majoring in history, and I am also pre-med. April's next for me.
Hi, my name is April. I'm a rising sophomore at Princeton. I'm not sure about my major, but I am planning on pre-med. And next to me is Charlotte.
Hi, my name is Charlotte Kunish. I am going to be a rising sophomore at Princeton on the pre-med track, and I'm currently studying biology and musical theater. And Lawrence?
Hi, everyone. My name is Lawrence, and I'm a rising junior studying biology on the pre-medical track.
Okay, well, so what we'll do is we'll try to have, about 40 minutes of presentation and maybe leave a little bit of time towards the end for some questions and answers, because I do feel that this is a very actionable plan, and this is going to be really interesting, and I think very interactive for the future. So please feel free to share your screen and get going.
Okay, I'm going to go ahead.
Hello. Oh, yeah. So as Zach introduced, today we'll be presenting our action plan so that we can have a permanent program at FIBUSPAM to do cornea transplants.
So I'll be explaining kind of like the needs analysis portion of this project. So based on our research, there really is a need for cornea transplantation in Ecuador due to a lot of diseases such as keratoconus, pterygium, and corneal deterioration that is mainly from environmental factors in the area. And the number of ophthalmologists capable of performing those transplants is really, really low. And since donor corneal tissues are really expensive, this cost of the procedure is extremely high and very unaffordable to the population. So as a result, there really is a strong motive to establish a permanent cornea transplant program at FIBUSPAM in order to meet the medical and financial needs of the population. So these are the few key statistics we found that kind of also support the need for a permanent transplantation program at FIBUSPAM. So the nearest surgeon performing cornea transplants is located in Cuenca, which is about 5 hours south of Riobamba by bus, which is really far. And on average, cornea transplant surgery costs about $5,000 to $6,000 per eye, and $1,000 to $3,000 of that cost basically originate from the price of donor corneas, which are typically imported from the United States. And Ecuador has an estimated 16 to 25 ophthalmologists per million people, which is, the ratio is not that great given the situation. And for every million people in Latin America and the Caribbean, 5,000 are blind, and 20,000 are visually impaired, with at least 66% of the blindness, which is attributable to treatable conditions.
So for this project, we had two main deliverables, and the first one was creating the actual action plan for forming this program at FIBUSPAM, which will provide the necessary information for subsequent development and implementation of this program. Second, we wanted to create some sort of promotional material. So we created a brochure with the aim of destigmatizing the procedure, explaining the surgery with some visuals, and also raising awareness about the causes of corneal deterioration and prevention methods that can be put in place. Our desired outcomes: first, of course, the improved sight and overall quality of life for those with ocular tissue degeneration. Enhanced outreach and a positive perception of the FIBUSPAM hospital among Ecuadorian communities. And then with our promotional brochure, hopefully improved general knowledge of ocular tissue deterioration and damage among the Ecuadorian population, as well as encouraging common utilization of protective and preventative measures. Some key considerations. So the first one is technology considerations, and information for this section was acquired through an interview with Dr. Carlos Gonzalez, responses to some of our questions from Dr. Silabal, and then general online research regarding cornea transplant equipment and tissue. So instrumentations for transplantation are needed for the uptake of this project, but according to Dr. Carlos, a lot of the already existing cataract surgery equipment can already be used. A standard eye kit is needed for the surgery, as well as a surgical microscope, but FIBUSPAM already has the microscope. And the small amount of equipment that FIBUSPAM does not already have is inexpensive, according to our interview with Dr. Carlos, which is something that's really exciting and makes this something that could actually be feasible. And remaining equipment can be brought by visiting surgeons or donated. So the main technology obstacle is acquiring the actual tissue for transplant, and cost of tissue varies, with the average cost being around $2,000. And the current plan for FIBUSPAM would be to connect with organizations then, such as one called Lions Vision Gift, which donates tissues to areas in need. And when it comes to tissue sourcing, that would sort of be the next step in research. I did a little research into tissue sourcing, went onto a lot of websites. The most successful one was the Eye Bank Association of America, which lists a lot of different eye banks in the country and internationally. The only sort of roadblock to that is when I went to a lot of the different eye bank websites, in order to actually get more information about acquiring that tissue or requesting that tissue, and for costs of any tissue, you had to have an account as a registered physician or hospital. So that would be the next step in finding out more about acquiring the tissue. Oh, I think you're on mute.
Sorry. For the marketplace analysis, information from this section was gathered from materials provided by Patch on the needs of the community in the Chimborazo region, which FIBUSPAM services. As stated above, there is a prevalence of ophthalmologic conditions within this community due to environmental and lifestyle factors, such as high levels of exposure to UV, dust and wind, agricultural labor, and lack of preventative measures, i.e. sunglasses. The target population for the program at its start will be the community in Chimborazo province. Later on, it is a goal to expand to other communities which demonstrate need and have limited resources. As of now, we believe the target market population for this program is clear. As far as organization and staffing is not a large consideration for the implementation of the cornea transplant program due to the current infrastructure and personnel at FIBUSPAM. Dr. Carlos is the main ophthalmologist on staff and will be performing the cornea transplants.
So as for business strategy, we did research into cornea transplantation and its need within the community that FIBUSPAM serves. And this was done through researching the various diseases that cause cornea deterioration. and basically the amount of people or estimated amount of people in that population that would have these diseases that would require an entire transplantation of the cornea. So thanks to Dr. Carlos Gonzalez and with Dr. Ball, we gathered information to understand this demand or this market for this proposed program and how to best address this demand in a manner that is both sustainable and impactful. That last point is very important because the goal of FIBUSPAM with this project is to provide restored sight for a very high need and a high risk population. So we want to be able to provide new corneas for anyone and everyone who needs them in Riobamba and its rural vicinity. We know that this town and its area, it's mainly indigenous, and most of these people are below the poverty line, even by Ecuadorian standards. So we want to be able to build a program that would be able to survive on its own and be able to provide such necessary procedures for those who do not have the ability to pay. So moving on, in terms of the competitive programs that we've identified, according to Zach, and thanks to Dr. Carlos Gonzalez, there's only one specialist who works in the city of Cuenca, which is located actually about 5 hours away by bus or by car to the south. So this competitor is located at a distance that would be very uncomfortable and costly for our target population to travel. And they also do not offer any free or subsidized cornea transplants. This was assumed in our research. And when speaking with Zach and with Dr. Carlos Gonzalez, I believe this assumption was proven true. And surgeries can cost between $5,000 and $6,000 US, with the actual cornea tissue accounting for about $2,500 to $3,000. So the plan is to distinguish ourselves from this competitor by sourcing such tissue from affordable sources such as Lionsgate, as Charlotte has mentioned earlier, and providing these transplants to this population at need, catered to the patient's ability to pay. So we will put priority on a culturally sensitive practice with regards to the indigenous population, because given our prior research into this population and their views on Western medicine, many are uncomfortable with being attended to by doctors that are not familiar with their own culture, and especially if they have to travel a long distance to see them. There's also quite a stigma surrounding organ donation and transplantation, which we had also assumed based on our research. And basically, our goal as of August now is to source affordable tissue and to identify staff that would be willing and able to perform this procedure. And as for marketing, we have an existing rapport with the local population. So we would be able to collaborate with local leaders and news sources to there's just information about the new transplant program, along with basically providing promotional material, which we have formed in the form of a pamphlet. And our target channels would be these communities and their leaders that would be very helpful in helping us spread the information for this new program based on FIBUSPAM's trusted reputation.
So moving on to capable, complementary, and scalable distribution infrastructure. To update the cornea transplantation process at the FIBUSPAM clinic will in of itself be very difficult to implement. There's a lot of moving pieces. First off, FIBUSPAM patch must secure medical equipment and corneas from outside organizations. Second, Dr. Carlos will need a team to help him perform surgeries day in and day out. And lastly, we'll have to circulate the promotional pamphlet that we created in order to effectively communicate to members of the community why they need the surgery, explain the health benefits, and convince them to trust Western medicine. Once that is done efficiently in the Chimborazo region, my team and I don't see how this program could not be implemented in other regions. The greatest barriers to replicating the program, however, are financial costs and manpower. Put it straightforward. The likelihood of establishing another clinic like FIBUSPAM in another rural community located 5 hours away seems highly unlikely. However, the possibility of having the educational pamphlet circulated from one community to the next and from one region to the next seems highly plausible. And from there, we might not be able to bring the clinic to other regions for cornea transplant, but people from other regions in need of cornea transplants will be able to come to us, and hopefully the clinic will be there to help them. Now, if we move on to the schedule, we see that most of the information was collected by Dr. Carlos and Silabel, so credit to them. But what we have done so far is 5 and 6, so I'll just brush over 1 through 4. So the first step in the schedule is to find cornea transplant tissue donors. So look for organizations like iBank, Lions Vision Gift. Second is to find cataract surgery equipment donors if possible. It's not necessarily needed, but you can never complain with more or better equipment. Third is create a feasible financial plan to support the cataract surgery process. We want this to be self-sustainable and to a certain extent help FIBUSPAM and Patch sort of profit from this procedure. And last is recruit and train surgical team and staff. As for 5 and 6, most of the cataract surgery equipment FIBUSPAM already has, so that's a bonus. And for creating and delivering promotional materials that destigmatize cornea transplantation, we have that through the pamphlet. Now, if we move on to the last, but relatively important, is the steps to ensure success. The first is education. Education is extremely important in order to increase the likelihood that people will want the surgery in the first place. We need to explain the cornea transplant surgery in a way that evokes confidence, and also explain to them that common eye diseases can be bad for their health, whether that's keratoconus, pterygium, or corneal deterioration. Second, as per Dr. Carlos and Silabel's recommendations, we must look for outside or external sources to receive corneas because they're very expensive, and paying for them out of pocket is not feasible for the clinic or for Patch. And third, which we already have pretty much completed, but more promotional material never harms anyone. If we can look to create a video, whether showing Dr. Carlos communicating with a patient, or a before and after a procedure, or any sort of a video demonstrating this is safe, this is efficient, and people can benefit from it, I think will go a long way to increasing awareness and to increase the number of people that will want the procedure.
And here is a little visual of the promotional material that we created. The brochure is something that would be easily distributable. Like my other team members have said, because of the fear surrounding transplants, especially anything to do with the eyes. Meredith's gonna pull it up so you can see it a little closer. But we tried to keep it very intuitive and very concise. So we explained the process very concisely, included some visuals, talked about some common causes. We also, explained and debunked some common myths surrounding cornea transplants, and some tips for, preventative things to help your overall eye health. So yeah, we'll just leave it on the screen for a couple seconds so that you can, get a good look at it. But yes, that's the end of our presentation. Thank you very much.
Well, thanks, everybody. Yeah, I thought you guys brought up a lot of good points here. And I also feel that perhaps, just having Paul here, he could also just speak a little bit about the capabilities of FIBUSPAM and also his vision on this. But it was very good. You guys were embracing some terms and some project management and project development format terms that you've probably never heard of before. So I really commend you for being able to put together something that in this style, because I understand it's a very brand new area for you guys to work in, and I think this is something really good that we can build upon, definitely.
So, Zach, I have one comment that might be helpful for them to know. You all mentioned the city of Cuenca several times, and you might be wondering, well, why is there this kind of capability in Cuenca and nowhere else? And that's because Cuenca is the primary retirement spot for Americans in Ecuador. And Americans love to, many of them love to retire to Ecuador, and Cuenca is where they go. There are magazines about retiring in Ecuador. It's super popular. So it's not surprising. I think the guy's name is Ponce, Dr. Ponce, and he has a big clinic there. And we've collaborated with him on a couple of things. But yeah, he's not caring for the poor. He's caring for rich Americans that have retired in Ecuador. The other thing is, you did a nice job on your translation for the brochure. Who did that?
I believe Meredith and I, we worked on it together, and everyone submitted their parts, and with the help of our Spanish teachers.
Yeah, that was well done. That all makes sense. And yeah, we actually were ready to do something like this before COVID, and it all kind of fell apart. So yeah, this is something we really want to do. The other thing I would mention is that on the call with us today is sort of the godfather of our entire eye care operation. Dr. Elwin Schwartz is on the call here, and it's really thanks to him and his friend Professor Ray Dennis that we have what we have, and he's responsible for planting the seed and watering it and donating a lot of the equipment, and so he can certainly add a lot more than I can about this. But yeah, nice job, everybody. Very nice job.
Yeah, I'd be happy to speak. I got here a little late. It's been a crazy week, which Paul and Sarah know about. But a couple of things I noticed on your presentation on the slides. I saw you kept talking about cataract instrumentation. I think you meant corneal instrumentation, which is totally different than what we have in the clinic now for cataract surgery. That was one thing that struck me. And you're going to need a fair amount, because every time you do a corneal transplant, it's not always the same size. So you need a whole series of trephines, which is what makes the corneal incision. The second thing I noticed that wasn't touched upon, which actually is probably one of the more critical things for us in the United States who do corneal transplants, is postoperative care. And that to me is a big issue that I haven't heard addressed. To have a successful postoperative corneal transplant takes at least a year. And it's a year of daily medications, both antibiotics and anti-inflammatories in a certain mix that if it's not just right, the cornea will reject. So this is something we have to give very, very serious thought to if we are planning corneal transplantation. As Paul mentioned, in Cuenca, it's not so much an issue because it's Americans with money who stay right there. But if we're thinking of doing people within Chimborazo province, that could be a major hurdle to overcome to make sure they're getting proper care and proper follow-up on at least a monthly basis for a year.
So if I could just amplify, Elwin, just a little bit, so that these students have not been able to go down to the clinic. So right. They might not realize that you're taking a patient and you might be able to bus him up from the Amazon or from one of the remote communities in the province. You might be able to bus them into the clinic, but eventually they have to leave. And what are they going back to? They're going back to filthy conditions, filthy water. And so, Elwin's point is very well taken, that, and they have to follow instructions, and you don't know if they're going to follow their instructions. They're out tending their animals, and and they have to survive, and they have to go out and tend their crops, and maybe they speak a little bit more Quechua than we thought, and maybe they didn't get all the instructions while Elwin was talking. And we do our best to put things in writing, but we don't often put it in writing in Quechua. Luckily for us, many of the staff at the clinic are indigenous and speak Quechua, thank goodness. But that's also difficult. One of the things you should know, I noticed it came up in the session yesterday, is there are many Quechuas. So the indigenous communities throughout the Andes have tried to create what they called Quechua Unificada, where they have a unified language so that these communities can communicate with each other. But if you go down to Macas, for example, on the outskirts of the Amazon, they won't understand the person that's coming from the Andes, even though they're only 4 hours apart. So there's all kinds of different idiomatic expressions and all kinds of things going on. So it's the idea of follow-up care is super important, as Elwin is suggesting, but it's also super challenging. And it's also because, you take somebody that had to ride a horse to get to where the bus is, and then a 4-hour bus ride from there is a very different thing that you might not be able to imagine, but this is what people have to go through. So it's not like, oh honey, my eye doesn't feel right today. Can you take me down to the doctor's office? It's not like that. And so it's a little bit more challenging than that.
Yeah, the other thing is, unlike cataract surgery, which I've been with Carlos many times, and he doesn't use any sutures at all. With a corneal transplant, it's usually somewhere between 12 and 16 sutures that are thinner than Paul's hair there. And activity has to be limited, which for a lot of these people can't be. Like Paul said, getting on a horse or on a donkey. They're going to be bouncing around. And like I said, the surgery is usually the easy part of a corneal transplantation. It's post-operative care and post-operative cleanliness and everything else. The other thing is obtaining corneas in this country now, they're all freeze-dried and they're banked. I'm not certain, I don't think there would be a bank in Ecuador, or possibly even could be. And then you're talking about obtaining corneas, and they all have to be tested beforehand for certain diseases that the individual may have had who is wanting to donate the cornea. So I see that as more of a logistical problem than even getting the patient into the clinic. Because once the cornea is harvested, you only have a limited period of time to get that cornea onto the operating table and into the patient. So, and I don't even know if there's any teams. I doubt there are teams to harvest corneas on patients who pass away in Ecuador. They could be trained, but to get that up and running could take several years. And then, of course, there's the politics of where the population is. You're going to get your largest donor population from major metropolitan areas. And then will people want to not let those corneas head up towards Riobamba? Those are thoughts that cross my mind in terms of logistics.
Yeah, and I think during their preliminary research that they defined that there were certain regions that have cornea donation in Ecuador. But I noticed one thing on that, but also this team is going to be handing over an actual physical plan too. And something that wasn't in the presentation was Dr. Carlos gave quite a bit of feedback on post-surgery, post-operating care, and the importance of that. So yeah, he did cover that quite extensively, and he did. That's the reason for a lot of the reason why there are some rejections and some some problems is because some people just want, like, they can't afford to take off a certain amount of time from work, or they just they just want to get back to their own lives. And it's the homes that they live in are, your dirt floors and stuff like that. And it is conducive to recovery. So
Yeah, thanks, Zach. I appreciate that. It's also affording a year's worth of topical medications. So, and it's a minimum of a year. So.
Wow. Zach, is there time for me to make a couple of other comments that sort of bleed into others? It's related, but it bleeds into other surgical areas that might be helpful for them to know, but I don't want to take up a lot of time.
No, I think the team is done with their presentation, so we can,
Okay.
Yeah.
All right, so what I want to comment on is relates to having the clinic in the first place. And Elwyn's comments make me realize and want to emphasize one of the things that is so valuable about having a clinic. I've led a number of medical missions to a number of different places in South and Central America. And hospitals will generally let you in. They'll generally let you use their hospital and ram around for a week. However, many hospitals in Ecuador don't allow it anymore. And why is that? Because of what Elwyn brought up, which is to say, you're going to come into my hospital, you're going to do 50 cleft lip surgeries, and then you're going to leave. Who's going to take care of the kids that are bleeding when you leave? When they blow their sutures out, because the mother really needs to nurse, and the sucking causes the whole lip to break apart, who's going to take care of that? And so a lot of the hospitals have said, no, you're not coming in here because we're sick of you leaving your problems behind. Having the clinic solves that. That's one of the things that I love so much about it, is that a team can go in there and they can do surgery and then leave with the confidence of knowing that there are doctors there to take care of any problems that come up after they leave. This is super important. Whether it's a gallbladder surgery or a hernia or an ear case or a lip case, the doctors get home and they actually get an email from us that says, little David is doing okay. Little Elwyn, yep, he's doing just fine. So-and-so had to come back in. He needed there was some bleeding. We were able to blah, blah, blah. So that's number one. Number two, I want to give you an example of some of the realities that we face when we work in other hospitals. We used to work in the military hospital in Riobamba, which during the heyday of oil and gas prices about 10 years ago was very modern, very well equipped, 10, 15 years ago. And I was super jealous of it. We used to work there. The last time we worked there was with an ENT surgeon by the name of Dr. Howard Bowie. And one of the things that was really nice about this military hospital was that they had this beautiful backup generator, because the power goes out in Riobamba quite often. They had this beautiful backup generator and a backup generator to that generator. Well, wouldn't you know it, we've got 2 patients on the table one afternoon. The power goes out, neither generator worked. We could have lost those patients. As it turned out, I have pictures of all of the team standing with their iPhones, with their iPhone lights on to light up the patient to be able to go. And luckily they were almost done. They were suturing. So we were enraged by that because we could have killed 2 patients, right? And what we found out later is that the director of the hospital knew that both of his generators were down and never told us. And that was the last time we ever worked in the military hospital in Riobamba, which has become a rundown mess because the government is broke. And now we work at the clinic, which is extremely well equipped, safe. We have a generator that's actually named after Sarah Marjane. I don't know if you guys know that. but we named it Sarah Marjane because she was responsible for finding the money that we needed to buy it. But anyway, I just wanted to tell you that story so that you really understand how broken these countries are and how awful the conditions can be in the places where you work. I also I'll give you one other example. You know, if someday you might remember this, if you decide to try to go down and do a mission. I was working in the children's hospital in Riobamba one time, and the director of the hospital called me into his office at noontime, and he put his finger on his big, huge wooden desk, and he was extorting money from me. And he said, "Paul, I need $500 to help run this hospital. If you don't give me $500, I want all your surgeries stopped." If you can imagine it. And I said, "When would you like this money?" And he put his finger down on the thing and he said, "Right now." So these are the realities of working in a developing country. Issues relating to corruption, extortion, issues relating to the quality of the operating rooms, the quality of the equipment. Anyway, I won't go on. I don't want to waste a lot of time, Zach, but I just wanted to give them a little bit of that background, partly so that they understand how valuable the clinic is.
Yeah, and thanks for bringing up some of those hurdles too. I mean, during this process, we run at a very rapid pace, and you know, some are missed, and you know, some things are very, very hard to convey without being in person too. And I think you know, your stories are you know really help the interns understand about just the reality and of the situation down there. We did talk a little bit about with myself and my own experiences in the late 2000s and FIBUSPAM and Pacha's experience now with just importation and getting stuff through customs, and stuff doesn't just easily show up there. And there's a lot of hurdles along the way, and unfortunately there are some bad elements that impede that as well. And it's very much a reality down there. The difficulties that are started by leaders and by people in between. So, but yeah, does anybody else have any questions actually perhaps for Paul or Dr. Schwartz in regards to the programs or in regards to the feasibility of a cornea transplant action plan in the future? You guys had a lot of questions for Dr. Carlos and Dr. Balls, and we're very thankful for the collaboration of Dr. Carlos on this one. And he seems quite excited about it down there. So hopefully we can build upon this plan, get it going in the future. Well, if not, we'll take a little recess and then we'll be back here at 5 o'clock for the Training the Future program. So,
super.
Thank you guys very much. And
thanks, Zach.
Thank you.